It's my pleasure now to introduce our next speaker. It's Dr. Mohammad Mawardi. He is a consultant gastroenterology and transplant hepatology and currently the program director at King Faisal Specialist Hospital and Research Center in Jeddah. Dr. Mawardi did his training in internal medicine, GI, and hepatology at the University of Western Ontario. Dr. Mawardi will be speaking today about drug-induced liver injury. Please, Dr. Mawardi.
Thank you, Mohammed. Thank you, Dr. Ibrahim. Good morning. I was asked to and assigned a session to talk about drug-induced liver injury, and I find it a quite interesting topic and important in our community where drugs and herbal medication play quite a good role in our daily life, and increasing in awareness between the gastroenterologists and MDs and the public population is mandatory. So I will go over during my session to talk about the impact of drug-induced liver injury worldwide, classification of it, and risk factors, and then practical approach to the patient with suspected drug-induced liver injury. And at the end, I will be talking about some evidence-based management for the daily. So worldwide, when I went through the literature, I find it very difficult or generally difficult to report or to have good cohorts and studies to talk about the estimation of the incidence of drug-induced liver injury. There are so many reasons for that. Lots of those drug-induced liver injury cases are not reported, and there is no diagnostic test to assign and to say that this agent is definitely contributing. It is not all the time, and lots of patients are asymptomatic when they present with it, and so it's not an easy thing to report. Three major case studies were documented in France, Iceland, and Korea, where the general estimated incidence of drug-induced liver injury, the crude incidence rates were reported between 19 to 12 per 100,000 case. And I think it is still underreported. We know that drug-induced liver injury is one of the major causes of abandonment and withdrawal of the drugs in our market. Most of those studies reported between different countries were considered prospective studies, but there were also retrospective studies in different countries. And in the United States, the studies reported between 2004 and 2013 reported a total number of cases of 899, where antimicrobials contributed to almost 45% of the cases. So worldwide, the highest number of prospective data were available in Iceland and Spain. Retrospective data were available in the States and in Australia, and the rest of the countries were underreported, as you can see. So still, we have limited data to report to talk about the agents and causing drug-induced liver injury. In sub-classification, there's the top-notch or the top group of medications listed causing drug-induced liver injuries in different countries. As you can see, the highest percentage were antibiotics between different case studies between Iceland, India, Spain, Sweden, and United States, where United States, 45% of the agents were reported to be secondary to antimicrobials, and the rest varied between herbal treatment, CNS, or anticonvulsants, and hypolipidemic agents. Again, in states, the top 10 agents causing idiosyncratic reactions reported are listed here. 9 out of the 10 agents, as you can see, are antimicrobials, and the bottom line is the diclofenac. So how much the drug-induced liver injury is playing an impact on to acute liver failure as a complication. So in the registry in USA, as you can see, between 1996 and 2016, almost 46% of the cases of acute liver failure were secondary to acetaminophen. And generally, the general estimation of drug-induced agents causing liver failure were around 11%. So you can see how much is the impact of medication to cause acute liver failure. Acetaminophen, INH, valproic acid, phenytoin, and propylthiouracil was responsible for 15% of liver transplantation in USA in a report of 2004 in Journal of Liver Transplantation. So how do we classify drug-induced liver injury and approach-wise? So you can classify it according to the type of to the pattern of the injury on the cell. Is it hepatocellular or cholestatic or mixed? And you count on that by using the R value, where you divide up the upper normal limit of the ALT to the alkaline phosphatase. And then you see, you either classify it into hepatocellular if the ratio is more than 5, or less than 2, cholestatic if it is less than 2, or mixed pattern if it is between 2 and 5. And the best outcome in such cases are the mixed form, where the worst outcome is the hepatocellular pattern. Between different case studies reported in different countries, the highest percentage of the pattern of an injury were reported to be hepatocellular, and then the cholestatic form, and then the mixed. So as a classification of the way of the injury into the liver, it can be classified in two major forms. The type 1, which is an intrinsic, and it is dose-dependent. And type 2 is idiosyncratic reaction, where it can happen anytime according to the latency period of the agent. And although there is always a lower threshold or certain threshold of a dose, where beyond that you can start to see a damage. And it's usually the type B1 is unpredictable. When you go over, or before releasing any medication, so the drug goes into different phases of studies. Those phases of studies between animal study and then phase 1, 2, and 3, where the type 1 and the dose-dependent toxicity can be assessed. The idiosyncratic type of reaction start to be assessed at the phase 3, and you can start to see it further in post-marketing form. So that's the difference when the agent or the companies, before releasing the agents, they assess the toxicity according to the phase and the stage of the disease, the agent. So drugs associated with type A, the top agents reported to be the acetaminophen, amiodarone, cyclophosphamide, cyclosporin, methotrexate, niacin. So the mechanism of the injury can be classified either in the intrinsic form, it would be direct, where there is a toxin or metabolite reacts with multiple targets, resulting in massive disruption, or indirect form, where disruption of specific metabolic pathway. And the idiosyncratic form is either immunological, where drug metabolite react with macromolecules to form hapten for B and cell-mediated immune response, or a metabolic form where there is an increase in susceptibility to the injury due to genetic or acquired inability to detoxify the injurious metabolite. I'm not going to go much into the receptor form and how does it work. But what I would like you to understand is the main mechanism of the damage by the drug-induced liver injury is causing an apoptosis and necrosis in the cells. And that happens through the action of the agent on different receptors within the liver and the hepatocytes. Okay, what about the risk factors? We classify the risk factors contributing to the drug-induced liver injury into either host risk factors, including the age, more than 60, for example, gender, being female, pregnancy, malnourishment, obesity, diabetes, and having comorbidities, environmental factors like smoking, alcohol history, infection, inflammatory episodes, and drug-related factors including daily dose, metabolic profile, class effect, and drug interaction and polypharmacy. If we divided the risk factors according to the type of the injury, so for type 1, for type A, it depends on the high dose exposure, the chronic exposure, and pre-existing hepatic dysfunction. While the type V1, a concomitant medication and polypharmacy, having an underlying infection, immunocompromised people like an HIV, an extreme of age, female gender, and genetic variation, all those factors play a role in causing the damage and the injury. So female, being a gender, is a risk factor for hepatocellular form of acute liver failure, Special agents like minocycline, methyl-dopa, nitrofurantoin, diclofenac have higher susceptibility for damage in patients being a female. Age more than 60 is associated with cholestatic form of drug-induced liver injury. DLI secondary to methotrexate anti-TB can increase with diabetes. Heavy alcohol and consumption is associated with methotrexate and INH drug-induced liver injury. So for type B, form of the drug-induced liver injury, it can be subclassified in non-immunological form, where the latency period is less than 6 months, and it's due to the alteration of the metabolic pathway resulting in increase of the toxic compound, and immunological form, which can be subclassified in autoimmune, like causing nausea, vomiting, and abdominal pain, and high IgG with autoimmune pathology in the biopsy findings, and immunoallergic form, which the patient that present with fever, rash, eosinophilia, lymphocytosis, and usually such an agents can respond to steroids. So it's important to have an idea about the way of the presentation, which will have my impact on the treatment and applying the treatment on the patient. So how do I approach any case with drug-induced liver injury? History, history, history. So detailed history is absolutely mandatory in getting further information and guiding us in an approach any patient with elevated liver enzymes. We get lots of patients where they don't know that herbal treatment for herbal use for a long period of time, or over-the-counter, or other medications or vitamins, they don't know that they have an idea, they contribute in causing a liver injury. So a detailed history, at least for the last 6 months, of any history of utilization of any agent, including over-the-counter and herbal treatment, is important. Then when you assess any patient, you use the R value to classify whether the pattern is hepatocellular or cholestatic or mixed form. So if it is in hepatocellular, this is the time when you start to go the usual workup with a viral screen, including hepatitis A, B, C, and E. And for the second line workup, you can send for CMV and EBV PCR with a background of ultrasound imaging. And then, according to the results, you take the next step for the workup. If it is a cholestatic form of pattern, this is the time that you go into workup like an MRCP, ERCP, if there is a need to do that. And then, when do we need to do a liver biopsy? So a liver biopsy is not always mandatory, but it's indicated when there is a suspicion of underlying autoimmune process or autoimmune hepatitis, or if there is a sustained drug-induced injury for more than 60 days, or progressive worsening of the liver enzymes, even with the cessation of the suspected agent, or when considering the need of the use or re-exposure of the agent again. This is the time that you need to do a liver biopsy. So again, workup and the diagnosis is usually a diagnosis of exclusion. Detailed history and judicious use of blood test and imaging is important, and the approach can be tailored according to the injury pattern. As you can see, there is no single pathology findings that's attributed to the drug-induced liver injury. So every agent has its own peculiar finding in the pathology. I can give you an example. Methotrexate will give you some sort of microvesicular steatosis with steatohepatitis. Anabolic steroid can give you cholestatic hepatitis. Acetaminophen over toxicity can give you a mixed form. Minocycline can give you an autoimmune kind of findings where there's a lymphoplasmacytic infiltrate, rosette formation, interface hepatitis. So, what are the histological features that should prompt the search for a drug injury? Eosinophilia and granulomas, think about hypersensitivity reaction. Zonal necrosis will include zonal variation in the enzymes. Think about any agent that works on cytochrome P450. Massive necrosis, including that indicates severe injury of many drugs. working on intrinsic and idiosyncratic reaction. Microvesicular steatosis, that means there is a background of mitochondrial injury. Vascular injury, we'll think about toxic injury to the endothelial cells. Mixed pattern, cholestatic hepatitis, steatosis, and necrosis, think about a medication like Tylenol or acetaminophen. Hay's law. So Hay-Zimmerman is one of the expert who provided this theory about any agent with any agent suspected of drug-induced liver injury. So if the hepatocellular injury causes jaundice in patient during phase 3 trial, then for every 10 jaundice patients, 1 will have an acute liver failure. An onset of jaundice in combination with drug-induced hepatocellular injury is associated with mortality of 10 to 50% due to the liver failure. Different category or diagnostic scales have been proposed. One of them is the ROCAM causality agent assessment method. It contained different perspective and items through the history, where at the end, and you sum up the points, and according to the points, you assess whether there is a strong causality between the agent used and the hepatotoxicity or not. The problem with such a diagnostic scale is not friendly use, is clumsy, and the information needed sometimes is challenging. One of them is you need to do a de-challenge, a re-challenge of the agent. If there is a strong damage, you will be scared the hell that you don't want to introduce the agent again. So treatment-wise, stop the cis-offending drug. That's the main treatment. Think about antidote. And I'm going to present, I'm going to talk about the N-acetylcysteine later, but carnitine has been used in valproic acid toxicity and cholestyramine and leflunomide. Steroids is recommended if there is a suspected background of autoimmune pattern or eosinophilic pattern. Role of steroids in acute liver failure and sinusoidal obstruction syndrome is still controversial. Orthodeoxycholic acid, silymarin, and glycyrrhizine, there's still some role of it. N-acetylcysteine has been well established in use as an antidote agent for acetaminophen since 1988, where 11,000 cases were looked at of suspected acetaminophen overdose, and a total of 2,540 patients used or received N-acetylcysteine for acetaminophen toxicity. So the results was hepatotoxicity developed only in 6% of patients at probable risk when NAC was started within 10 hours of the ingestion, and 26% of such patient therapy was begun within 10 to 24 hours after ingestion. So now N-acetylcysteine is the backstone agent to be used for acetaminophen-induced acute liver failure.
2 minutes left.
Okay. Sorry. What about the use of N-acetylcysteine in non-acetaminophen-induced drug-induced liver injury? If you look at the AASLD paper, the general recommendation that there is some rule of N-acetylcysteine of its use in such agents. And that based on this study reported in 2009, where 173 patients were randomized in double-blind trial, and the hepatotoxicity, there was a trend towards survival benefit with the utilization of N-acetylcysteine, but there was no definite statistical significance of survival in such an agent. But we still recommend it to be used in non-acetaminophen-induced drug-induced liver failure. What about extracorporeal liver system, a supporting system, including artificial liver support, bioartificial support system, and albumin dialysis, MARS? There's no survival benefit of its use, but it has been approved in Europe and in USA for improving the liver, accelerating the liver recovery process, but there is no definite survival benefit. Different resources has been advised to be used whenever you suspect a drug-induced liver injury with any agent. So my conclusion is drug-induced liver injury is the leading cause of acute liver failure. Detailed history is an absolute mandatory form for any patient for workup and diagnosis. Agent withdrawal is the main treatment intervention for any form of drug-induced liver injury, and different resources are available for references for any drugs inquiry for a potential drug. Thank you.
Thank you, Dr. Mawardi. I'd like to ask the speakers to come to the stage for questions. The app can be used to ask questions.
Maybe I should start with you, Mohammed. A lot of patients are on polypharmacy. And in addition to the polypharmacy, some of these patients may get TB, for example, and there are 4 more new drugs that are potentially hepatotoxic may be added. When these patients develop hepatic injury, how do you dissect out which agent is the culprit so you can stop that agent? The patient may be taking 5 or 3 or 4 hepatotoxic medications. Can you tell us your approach? Yes.
Thank you, Dr. Ibrahim. This is quite a very challenging question. In our culture and community, as you can, all of you guys, definitely you deal with patients where they have a polypharmacy, and still, in digging further and further in the history, you find out that those patients, they use other herbal medications that they think that they don't have any role in the toxicity. What my approach is, I look at those, I get the detailed history, and I list the medication. And then if the patient has a baseline normal liver function, then I try to take out and skip or omit or recommend to the patient to omit drugs which will have a high toxicity potential during my use or my future use of any treatment form. And then I'll restart those treatments after completing the course of my agent that I'm going to use. So subclassifying how much the patient is in need of such an agent is absolutely important. And then the emphasis on the patient that you really need to avoid herbal treatment, you really need to avoid over-the-counter, because this can contribute to, the polypharmacy can contribute to hepatotoxicity. So this is absolutely important. I'll give you 1 minute, just an example. We got a case, a dialysis patient, and came with a sudden onset of hepatitis form, an acute form of liver enzymes, where the liver enzymes were in the 10 times the normal. So basically, we tried to get all the workup. All the workup was negative. And then in further future history detailed, digging in the history, he said, I'm using the Samgh al-Arabi later on in a couple of weeks. For how long have you been using it? Oh, دكتور أنا استخدمته من 3 أسابيع قبل ما أجي العيادة. Okay. So you can see that a detailed history is extremely important to the patient.
Thank you. It's also very important. Sometimes the patient on first encounter deny taking some medication. They only reveal it if you really ask them in more details. Thank you. Mohammed, you have questions in the mobile?
Dr. Hamad, please go ahead.
My question to Mohammed al-Sheikh, excellent presentation. I was wondering why we don't replace microwave is better than RFA. So why we don't go for microwave? Less cheaper, less sessions, less heat. This is number 1. And the same for taste and tear. Why not tear?
It's okay. Thank you for your questions. First of all, the availability of these techniques is very important. I can tell you for the microwave, it is available in Saudi market just the last 2 years, for example.
It is cheaper. Right?
It's not cheaper. As a machine is not cheaper, but you can use the needle itself. One needle, you can use it multiple times. So maybe if you calculate it, it will be cheaper. But RFA, since 2001, the people using this technique, so they are mastering this technique, and they know the limit of their zone. The problem with the ablation therapy is to determine or to know your heating zone, how to control it. So the experience with the microwave is less. But I can say in HCC right now, in the liver in general, not only HCC, the experience of the people get better with the time. So the availability and how you master it, your training about this technique. The second question regarding TACE and tear, also the same. But the difference here is TACE is very common and very classic, available, cheap, even though the two techniques, the conventional or DC beads, the conventional, it's very cheap and you can use it in any center. You don't need to pay a lot for it. Another thing, tear, until now there is a lack of a controlled randomized trial head-to-head with the TACE to see the effectiveness of this treatment.
Thank you.
Next question from the audience to Dr. Hamdan. Do you use Lasix-induced natriuresis to diagnose refractory ascites? And is it required in most of cases?
We use Lasix natriuresis.
Yes, there is one clinical trial that looked into the effect of giving the patient intravenous Lasix on the first presentation with ascites and looked whether they are excreting more than 50 or less than 50. If they are excreting less than 50 millimole over 8 hours, this patient probably will be a refractory sort of ascites, and then diuretic might not be helpful. This is an old trial, but there is something about the use of intravenous Lasix. Yeah.
Thank you. Another question from the audience to Dr. Mohammad Mawardi. What's the last recommendation regarding methotrexate-induced liver injury? Any role for FibroScan and follow-up of patients who are using methotrexate for a long period of time?
Yeah, excellent question. We know that there are so many studies that talked about having a liver damage even with the normal liver enzymes. So what I will do and I recommend is you get a detailed history about the total average cumulative dose of methotrexate use over years. If you start to exceed those more than 4 gram, I would recommend going for FibroScan. If the FibroScan is suspicious, F2 or more, then go ahead and do a liver biopsy. And if the liver biopsy is showing an active steatohepatitis, this is the time that you need to withdraw the medication.
Thank you.
Thank you. Another question from the audience to Dr. Mohammed Sheikh. What's the role of external radiation in the management of HCC? External beam radiation in the management of HCC?
This is the new competitor for the radiology intervention. So actually, I don't know. But what I saw that in absence of the availability of other modalities like the TARE, and according to the experience of our colleagues in the radiation oncology, they are speaking about good results, but personally I didn't know any study compared this technique to other modalities.
A question to Dr. Hamdan.
My question regarding the DILI. How long the histological changes of liver persist after stopping the offending drug, and does it really correlate always with the LFTs?
Sorry, your question is how much time does it take for the histological findings to resolve?
Yeah.
Yeah, this is quite variable. You know, as an example, autoimmune hepatitis it takes around 3 months for the histological finding to resolve from the time of normalization of liver enzyme. Again, this is variable also. It depends on the agent, the severity of the damage to the liver. So I would rely mainly on the clinical presentation and the blood works when you decide to start any other treatment.
Thank you. Question to Hamdan. Many patients are labeled refractory ascites simply because they cheat themselves with salt intake. Can you elaborate on this, because it's very important, and those who cut salt tends to resolve their ascites with the help of diuretics. Please.
I'll say that transient, what we call a transient refractory ascites. There are many reasons for transient refractory ascites. One of them is patient non-adherence to low salt diet. And we tend to do spot urinary sodium potassium excretion and see whether the patient is excreting or not on diuretic. If they are excreting sodium, the ratio is more than 1, that means they are excreting sodium, but the patient is not, the ascites is not resolving and edema is still there, we think this is a non-adherence to the salt. But if the patient is excreting, is not excreting sodium and the ratio is less than 1, and the ascites is not resolving, then we will say whether the patient is taking the diuretic, and if he is taking the diuretic, then we try to push up the diuretic dose. Another important thing is that we see from non-gastroenterologists and hepatologists that patients with ascites may be treated with monotherapy, with Lasix or furosemide, which is not the drug of choice in ascites. Or some of the patients actually, they are on inadequate dose of diuretic, and thiazide diuretic is being added to the management, which is not, does not address the pathophysiology of the ascites on those patients. Drugs I have mentioned about, drugs that could impair the urinary excretion, like non-steroidal anti-inflammatory medication, and the angiotensin receptor blockers, also they blunt the diuretic response. They not only impair the kidney function, but they make the diuresis less effective with diuretic. So we look into all these things.
Thank you. Mohammed, if you can tell us when to refer a patient for liver transplant once you diagnose liver injury induced by drugs or herbs.
I would recommend to refer any patient to tertiary care center for a workup for a liver transplant if you start to suspect a fulminant liver failure, which is an acute onset of encephalopathy with a background of coagulopathy within the from 1 week from the onset of introducing the agent. Provided that there is no contraindication, like extreme, let's say, an age more than 70, patients unstable, or if there is no other contraindication, okay? So this is the time that give a call, talk to your colleagues in the tertiary care center, prepare the patient to be transferred to a good intensive care unit where you have a good support and they can do the management. We receive such cases in Jeddah. We don't have a transplant center in Jeddah at King Faisal and Western region right now at the current moment, but we do receive such cases we deal with it and we start to communicate with our colleagues in Riyadh.
Thank you.
There's another question from the audience to Dr. Mawardi. When to consider an urgent liver biopsy? And he mentioned like comment about 60 days.
Yeah. So if you're suspecting an autoimmune hepatitis, or if you have a persistent elevation of the liver enzymes with no recovery for more than 60 days, or if there is a further clinical deterioration of the patient, and despite of the stopping of the offending agent, then go ahead and do a liver biopsy. I just want to mention something. Having a very good pathologist and pathology department is a key role here, because they can guide you and give you very good information on where are we going. That will affect your treatment plan.
Thank you. Before I take the next question, I will take it. I just need to comment on your slide, Dr. Muhammad, about surgical resection of hepatocellular carcinoma in about 12%. We see on our tumor board on weekly basis about 10 cases. We hardly find cases for surgical resection. In our experience, it does not exceed 1 to 2% from the cases that we see or refer to us, unless they are on a surveillance program where the tumor is detected early and can be offered curative therapy. Your comments, please.
This is our local experience, but these numbers are worldwide, and I agree with you. Yani my limited experience with these things, I can say I totally agree with you. Especially here in Saudi Arabia, we have a lot of data. We have a lot of differences compared ourselves to the world, but unfortunately we are not that active in doing researches and compared our data to others.
Most of the cases that we get are symptomatic and quite advanced.
That's
Your
it.
question, please. Final question here,
Yes,
and then we'll conclude.
my question is to Dr. Mohammed. Having to mention the Arabian gum, is there any scientific evidence that it causes liver damage or
الصمغ العربي?
yes?
I don't have any literature about that, but again, think about any herbal medication which has no literature, so there is always a potential for hepatotoxicity and damage.
Okay.
So always be attentive to such agents over the counter.
I have a patient who has been using the Arabic gum, and she developed, they use it actually, the kidney patient. I don't know why they're using it. There is something about the Arabic gum and the kidney patient. The same like the patient of Dr. Muhammad, who came with abnormal liver function test. And after full investigation, she did not give us that she's taking Arabic gum, liver biopsy consistent with an acute, mild sort of liver injury. And further questioning, we found she is taking the Arabic gum. So I think the Arabic gum maybe is mixed with something with it that can cause the hepatotoxicity. But this actually is a hepatotoxic, maybe in a kidney patient. The case that I have seen is a kidney dialysis patient, same like Dr. Muhammad.
So its effects on the kidneys are not even
Maybe the
proven
accommodation
yet.
is higher in these patients and they got toxicity on the liver rather than.
Yeah, you see, you go to Mahalat al-Atara and you see lots of agent and mixture. We don't know, as Dr. Hamdan said, it might be the agent, it might be the combination or the additive agent that's contributing to the damage. We don't know. We need further research to elaborate about the causality.
Yeah. In addition, many of the herbal mixture that are sold in many places have actually some drugs on them, medications, to enhance their effect sexually or diabetic, anti-diabetic or whatever. And they say these are magic mixture for diabetes or for vitiligo or for whatever. And this is some type of cheating, and it can be very deceiving and can be extremely dangerous as well for the patient. Anyway, thank you very much. We conclude our session. I would like to thank all our 3 excellent speakers and hope that we've answered most of the questions that we've received. We will reconvene at 13:25 with the opening remarks after Jum'ah prayer and after lunch. Thank you very much.
إن إنما المؤمنون إخوة فأصلحوا بين أخويكم واتقوا الله لعلكم ترحمون. يا أيها الذين آمنوا لا يسخر قوم من قوم عسى أن يكونوا خيرا منهم ولا نساء من نساء عسى أن يكن خيرا منهن ولا تلمزوا أنفسكم ولا تنابزوا بالألقاب بئس الاسم الفسوق بعد الإيمان ومن لم يتب فأولئك هم الظالمون. يا أيها الذين آمنوا اجتنبوا كثيرا من الظن إن بعض الظن إثم ولا تجسسوا ولا يغتب بعضكم بعضا أيحب أحدكم أن يأكل لحم أخيه ميتا فكرهتموه واتقوا الله إن الله تواب رحيم. يا أيها الناس إنا خلقناكم من ذكر وأنثى وجعلناكم شعوبا وقبائل لتعارفوا إن أكرمكم عند الله أتقاكم إن الله عليم خبير.
صدق الله العظيم.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين وبعد. أصحاب السعادة، الضيوف الأعزاء، الحضور الكريم، السلام عليكم ورحمة الله وبركاته. نيابة عن أعضاء اللجنة المنظمة واللجنة العلمية يطيب لي أن أرحب بكم أجمل ترحيب في هذا الحدث العلمي الملتقى السعودي لأمراض الجهاز الهضمي، وهو نتاج التعاون المثمر والبناء بين 3 من الجمعيات العلمية، إذ يعد المؤتمر السادس عشر للجمعية السعودية للجهاز الهضمي، المؤتمر الخامس للجمعية السعودية لأمراض وزراعة الكبد، المؤتمر الخامس للجمعية السعودية لأمراض الجهاز الهضمي والكبد والتغذية لدى الأطفال. فحياكم الله وأهلا وسهلا بالجميع. Excellencies, distinguished speakers, guests, ladies and gentlemen, on behalf of the organizing and scientific committees, it gives me a great pleasure to welcome you all to the Saudi Digestive Disease Forum, SDDF 2018. It's an honor to have you all gathering here. I would like to express my sincere thanks to all speakers and audience for their attendance and participation. SDDF is the product of cooperation of 3 associations. It is the 16th Conference for Saudi Gastroenterology Association, the 5th Conference for Saudi Association for the Study of Liver Diseases and Transplantation, and the 5th Conference for Saudi Society of Pediatric Gastroenterology, Hepatology and Nutrition. SDDF provides a very unique opportunity for all of us. It gives a chance for more collaboration between adult and pediatric healthcare professionals. The members of organizing and scientific committees have worked extremely hard for the last year to prepare an outstanding conference. We have prepared many workshops and forums to discuss many aspects, including GI motility, fibroscan, endoscopy, research methodology, leadership development, and other unique topics. We have accepted a number of high-quality abstracts for poster presentation. We have successfully managed the conference with electronic and online process for abstract submission, conference registration, interactive mobile application, and other services. Dear all, your strong support and active participation will make the SDDF 2018 a record-breaking event. I wish to take this opportunity to thank the presidents of SGA, Sasselt, and Saspigan for their extreme support. I also wish to thank all members of organizing and scientific committees for their great effort and outstanding achievement to have this event success. Organizing committee is pleased to provide maximum support. Please feel free to ask questions or help. Enjoy your participation in the SDDF 2018 and memorable time visiting Riyadh. We hope to see you next year with even more colleagues for SDDF 2019. Thank you. Have a wonderful day. Now we will proceed to the introductory video, then the speech of SGA President, followed by the speech of Sasselt President and Saspigan President.
بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على رسول الله. First of all, I'll have to give thanks where it's due. And I'd like to thank the organizing and the scientific committee for a wonderful job that has been presented since morning and even starting since yesterday. And I'll have to say that this effort has been going on for a year. The group that has been working on this program has been meeting regularly throughout the year, has put in a lot of effort and time, and I can see the impression from the first few hours of the meeting, but hopefully we'll get feedback at the end of the meeting of how we did what we did well, what we could improve on, and we'll build on that for upcoming years. All of this to say is that even during a session yesterday in one of the workshops, we were thinking about deeply, why are we doing all of this? What's the point in this? What's the end result of this meeting, this effort, this activity? Are we serving the community? Are we serving the patients? Are we serving our profession? Do we have a landmark that we're going to make regionally and internationally? And hopefully we're aiming to achieve all those milestones and endpoints. I think the move of the coalition between the three societies has been long awaited. There have been attempts, but non-sustainable. And it seems that the future looks bright, and we hope that this coalition continues in the future. And we'll leave that judgment up to the attendees. We'll see your feedback, your impressions, and we'll take it from there. But also, I'd like to welcome our international faculty. They did come from a long distance. And I'd like to welcome Professor Ayman Abdu, who showed up today, very thankfully. He's a past board member and have witnessed the evolution of this meeting and society. Our senior faculty, our mentors, our teachers are in the first row, and I'll have to give them due account that this meeting today is what they had planted years ago. And I'll have to thank for that. And I'll go into the details of the accomplishments of the society tomorrow, in addition to our colleagues. Each society will have its own accomplishments, but I think we've come a long way. We do strive to go to a better distance and have better outcomes, inshallah, in the future. And thank you very much for attending. This whole success is from you. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, Jum'ah Mubarakah for everybody. It's always difficult to find words after Dr. Majd al-Madi, but there's a few words I want to say. What you see today is a vision that happened 4 years ago, when we dreamed of having the three societies together to reach to this level. First of all, we started with our partner SGA to join in a national meeting that should reach an international level. And I think we achieved that, thanks God, for the last 2 years. This year is a very unique opportunity for us, where our vision and dreams definitely came true. The standard, the level that we hope to see in our local meeting is finally achieved. There is too many people to thank. Actually, I could spend the whole day thanking a lot of people, but the first thank is for you, audience, who came and gathered from adult gastroenterology and hepatology and pediatric gastroenterology and hepatology together today for this wonderful opportunities. The program is well chosen by a scientific committee who worked very hard from the three society. The organizing committee was joined over the last year to come to this day that we are so proud of. Thank you so much for everybody, and definitely over the next 24 hours we'll see a very exciting program. And thank you very much. Wish you a good day.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everybody. It is my pleasure to be with you on behalf of the Saudi Society of Pediatric Gastroenterology, Hepatology and Nutrition, SASBGAN. Really, it is our pleasure in SASBGAN to have the first Saudi Digestive Disease Forum. This nice, forum to be, including all the pediatric and adult gastroenterology. It is really a great effort that all the resources will be, in one pool instead of having 3 symposia. We hope that will be, continuous for next year's as a second and third forum. I would like to thank our colleague in the Saudi Gastroenterology Association and in the SASLT also as well. And would like to thank Dr. Mohammad Khatami with his great effort with his organizing committee and scientific committee. I would like to welcome everybody in this room. In pediatrics, maybe we thought that there is nothing, related to adult. Actually, we are all of them, all of us in like one team. We have transformation from pediatric to adult. It is good time that we discuss these issues in this forum, how we transfer patient when they become adolescent. Thank you again for this forum, and we hope that will continue for next year. Thank you very much.
Thank you so much for the presidents. We'd like now to invite all the attendees to attend the respective sessions. This session will be the main event. It will be an advanced endoscopy session. I would like to ask Dr. Majid Al-Madi and Dr. Abd Al-Hebi, who are co-chairing the session, to come to the podium. In the gastroenterology and hepatology board review, Professor Yusuf Kari and Dr. Ahmed Afghani will start the session, and then the pediatric session will be in the pediatric session group. Thank you so much.
Bismillah ar-Rahman ar-Rahim. So it's a pleasure and honor for us to have Professor James Lau from the Chinese University of Hong Kong. Most of you have seen his studies. He has landmark trials in the use of PPIs in GI bleeds. He also a number of publications in very high impact journals in advanced endoscopy. He's a surgeon by profession and a professional endoscopist. I'll have to give him that. And he's the head of the department.